are usually from fire or chemical burns. Children have a very particular way of burning. They usually burn from hot water or steam, or what we call scalding burns. So, and that is why one of my mentors, Professor Andre Lopsha, who is a renowned trauma surgeon and is the man who taught me everything I know about burns, he always said when he worked, he says, childhood burns are not accidents, but preventable occurrences. And that is one thing that gave me a passion about treating burns, because before we treat the child that is burned, we need to think of a burn in a very holistic way. If we think of scalding burns means the water usually falls on the child. So the pattern of burn distribution is usually from the head down. The other way that burns happens in children is children falling into water. And or another child having to handle hot beverages from one place to another place and somebody bumps. So that's why they're preventable. They're actually preventable. I mean, I can ask if anybody in the group, do you know the temperature of water in your geyser? In your house? Anybody?
Colleagues, feel free to type in there. I will read for Doc. What is your... I see
Or
no...
they can even talk.
I see 70 degrees. I see 100 degrees. I see it's not hot. Oh, it's hot. No idea.
Yeah. So the legal, according to South African legislation, temperature that should be in your geyser is about 55 degrees Celsius. And the reason why you do not know is because the contractor of your double-story house has put it at 100. It will burn that child full thickness burns. And because we did not also look, and the way we regulate our thermostats in our household depend on people trying to save electricity, so that nobody really knows what is the temperature in their household. And you can imagine, if there's anything above 55, it's going to cause burn. Imagine having the same geyser set at 40 degrees or 45. You're still going to get hot water to be able to bath and to be able to do everything you want to do, and it doesn't necessarily going to burn anybody, including your child. So that is where the prevention starts. The second thing is making sure that children do not handle things that are above their level that are hot. And then the third one, I always ask, and I've asked even my colleagues. So when you put water in the tub, in a bathtub, which one do you open first? Any answer to that?
Yeah. Yes, colleagues. I see cold.
You open hot or cold water first?
I've got age hot. I don't know. It's like people have an expectation of the correct answer, but it's
no. I mean, it's a discussion. Yeah. The reason why you open hot water is because
cold. Then it's mixed. Yeah.
Okay, good. I'm glad there are people who are opening cold water. Because you need to open cold water and warm your water. I would just give a scenario. If you want to bath with, let's say, 30 liters of water, and you want the temperature of that water to be 24 degrees, and you put 5 liters of hot water and then 25 liters of cold water to be able to get that to that temperature, you will get you the same temperature with the same volume of water. So if you put the cold one, 25, and put 5 afterwards, you will still get you the same temperature. So there is no reason for you to actually open hot water and then put cold water in it. You can put the same amount of cold water you want, and it will require you the same amount of hot water you want to get the temperature you desire. So that's one of the things you need to teach your child. If you have a child in the house, that we use hot water to warm cold water when we bath. It's not the other way around. Because most people open hot water, they quickly go fetch the soap and they come back, their child is burned. And it's 40 to 50 to 100% burns because the child has fallen into a bathtub. So the most important thing is we need to prevent this in the first place from happening. And we know that, I mean, we live in communities that comes from different socioeconomic status. But I mean, in my private practice, I still treat some of the richest, some of children comes from the richest households, and most of them, they have fallen into a hot bathtub. And I've always asked, but why is the bathtub having hot water? So it's about us as parents thinking the way we rethinking the way we basically deal with water. So without wasting your time, I am going to try, this is a very big topic, so I'm going to try to compress it by talking about the things that I think they are learning objectives for today. So I'm going to discuss a little bit of skin anatomy so that you understand what actually a burn is and what's the skin purpose. I'm going to classify the burns so that you know what we are talking about when you talk about epidermal burns, superficial dermal, deep dermal, full thickness burns, or traditionally what people used to call first degree, second degree, and third degree, which is not used anymore. Then I'm going to talk about my patient a little bit, the pathophysiology of what happens to a child when they get burned. And after that, I will talk about how do we clinically assess the child and what is expected out of you as non-surgical person. How do you provide that acute management? And then the most critical thing is what is the admission criteria and the referral protocols if you have to refer a child somewhere. Anything above that you need, it means you need an in-depth understanding of burns. I will be running a full day burns course with Dr. Nikki Aloto. She's a burn guru in this country. Has been doing burns for more than 15 years of her career in Pietermaritzburg. And every burn specialist in South Africa, when they do not know what to do, they call Nikki. So I had an opportunity to partner with her to do a pre-congress workshop on the 6th of November, where we will be doing a burns course. We will be looking at operative principles of burns, how to use a Hambi knife, the surgical part and the medical part of it, how to take care of a child in an who's burns in an ICU setting. So this will be a combined practical and clinical course that will address fluids, sedation, dressings, and how to apply dressings. What do you do in a patient who's in an ICU setting as a pediatrician? Because these patients are not there for ventilation, but they need critical care. And it's always interesting how I always get asked if the patient is intubated when I ask for critical care bed. And because of the pathophysiology of a burns child, they will not survive if they don't get admitted in a critical care environment. And I will share the link for anybody who's interested to register for the course. We still have spaces available. It is going to be able to go to give you in-depth. But just to get to a little bit of anatomy, Lesiko, I think I'm dealing with people who are doing pediatrics, or are there people outside of pediatrics here?
Yeah, it's a mixed group.
Lesiko, are you still there?
Yes, I was saying
it's a mixed group.
Yeah, it's a mixed group. So there's nurses,
good.
There's all assorted, basically.
That's good. That's I like that, because the burns in itself is a multidisciplinary a disease. You cannot treat the burns as an individual. Basically, when you treat a burn, you need a doctor that admits the patient. You need a nurse that's going to deal with the burn wound. You need an occupational therapy that is going to make the child understand and heal. You need a physiotherapist that's going to prevent the child from getting contractures and get the child to be moving. You might need a pediatrician. If the patient is going to critical care, you need a surgeon. When the child has to go to theater, you need an anesthetist who understands what kind of patients they are dealing with. So it's a multimodal management. That's why I'm happy that we've got all these people. So the first thing I would like to talk about is actually what is the pathology. The pathology is the skin. And the skin is the largest body in our, the largest organ in our body. So if I get a pneumothorax, guess what? It just affects my lung. If I burn, it affects the biggest organ in our body. That is why there is always a critical decision within the burn centers and the burns gurus in the world is what percentage of burn should be admitted for treatment. And I have asked this before I give a lecture, and then I'll give a lecture and ask again. Anybody knows what percentage of burn should be admitted in ICU and go to theater for management and all the resources in a tertiary institution?
I see 15 plus.
Anybody?
I see 15 plus. I see 50%, 30%, 20%. TBSA.
In ICU. Now they need to go to ICU. They need critical specialized care, burns unit. Yeah. So 50%.
Yeah, it's variable. 20%, 15%.
But the highest number, I want the highest number.
50 is what I've seen. 60 now.
All right. 60, all right. Yeah. Let me tell you, the best burns unit in the world will refuse any patient that has more than 60% full thickness burn. They will tell you, give the person morphine and let them die. They will not take them in their unit. Because it's impossible for a child who's got more than that percentage of burn, if it's full thickness burn, to actually live. They are going to suffer in ICU for 3 to 5 months and then eventually demise. And I'm going to try to explain to you why, right? Number one, as the skin we know is the largest body of our body. It provides a physiological barrier to all infections. Number two, it's for thermoregulation. For sensation, as we know, vitamin D synthesis. And then we have to look at the skin in terms of the anatomy. The skin is made up of the epidermis, the dermis, and the subcutaneous layers. And this is able to give us an idea of the levels of burn, which is where the percentages, the degrees come from. So the epidermis, we know, is a avascular layer. It's there's no nerves on the epidermis. It's made up of keratinocytes, melanocytes. That's why we black people don't have that much of issues with burns, with lung cells, Merkel cells, and it's replaced entirely every 48 hours. Every time you bath 2 days later, you get a new one. So it is not a problem if you burn your epidermis. And then you get to the dermis, and this is the most important, I think, thing to remember, that the dermis anatomically is composed of what we call the papillary layer and a reticular layer. And between those, we've got collagen and elastin, which provides support to skin, right? So that is why we distinguish between superficial dermal and deep dermal burn, because the recovery will be different, because exactly of the anatomical components like sweat gland, sebaceous gland, the muscle layer that provides collagen that you find. And that is also why some burns will give you scarring and some burns will not give you scarring. It's not because of the cream that was used or the dressing that was used why one gets a scar or no scar from burn. It literally is because of the division between the papillary layer and the reticular layer. So the papillary layer is able to be replenished because it's below that erector papillae muscle. So It's just once you burn above that, you are able to have collagen replacement, and anything below that is a little bit of a problem. Right. So the other important components. So the first one I said is understanding the level of burn, which I'll come into. The second most important thing with burns in children is the rule of 9 was thrown in the bag long time ago. It's for adults because children have different portions of body surface area per square per cube meter. That is why in children we use the loop or Browsler chart to provide a more accurate determination of the area of burn, which is not be able to be it's actually incomparable to using the rule of 9, because as I say, the proportions of the body actually matter. So as you can see, that the area of burn in children has letters and it has numbers. So I can say it's A plus 2 plus 3, and you as a pediatrician, as a pediatric surgeon, or somebody who treats children, you need to know exactly what I'm talking about. The area of 40% burns and all this in children is not necessarily what we talk about, but we are able to translate it into that. So if you look at the thorax, the front and the back of the thorax, which is the one place that children burn, because I explained to you that things fall on them, is 13% of the total skin area. And then if you look at the arms, it's 2 and 2, and this is numbers from front to back. But if you look at, when you look at the head, because the children's head differs in terms of percentage. So a 15-year-old who gets burned on their head, they only have 4% burns. But a child who gets burned in their face, they have a 9% burns, and it's a big difference. As you can see as well, about the thigh and the legs, the differences are quite significant, especially if a child comes with a burn to their entire head. That patient actually has 18% burns and is in a critical position.
Hi, Doc.
So
you may use your
am I still there?
Yes, I was saying you may use your mouse cursor to point at the areas
okay,
so that they can pay attention. Thanks.
Yeah. The second most important thing when you look at a burn is not only how much of the burn, because how much of the burn is also determined by the zones of injury. And this is where I love my nurses, because if they understand the slide, they understand how come a 10% burn that came from casualty, on day 10, the patient suddenly has 25% burn, and everybody does not know what happened. And they are now in burn shock, they have sepsis, and nobody understands. This was just a small wound. And I want us to look at it this way. So if you look at the superficial thickness burn or deep dermal burn, which I discussed earlier, there are 3 zones to every wound that you need to look at when you look and assess the wound. And this you can only assess after 48 hours. The first one is the zone of coagulation. That is exactly where the burn happened. So coagulation happens, dead tissue is going to come from there. That's what you see first time. It's like, oh, he has burned, he's 10%. No, it's not 10%. Because after that, there's a zone of stasis. There's a decreased perfusion, but it's salvageable. And that salvage has to do with 2 things: keeping the patient perfused, hemodynamically stable, or else the burn is going to extend. And then the third zone is the zone of hyperemia, the red, nice pink look-alike area, which has increased perfusion because the body is trying to protect itself. It usually survives unless interrupted by sepsis and hemodynamic instability. So the 5% burn that you have discharged home, did not give fluids to, comes back 2 weeks later, they've got a 10% burn, and they're hemodynamically unstable, and they've got sepsis. That is exactly what happens. So you need to think of the burn in terms of what you see, look around what you have seen, and calculate that within the burn itself. That is why it's very critical to remove all blisters, not one, all blisters, to undress the patient completely if you're treating a patient with burns, right? Okay. And then I'm going to now go into the different classifications of burns. Basically, traditionally, we had first degree, second degree, and third degree. But I will try to show you now what we use. We look at the anatomy, which is the epidermis and the dermis and subcutaneous tissue. The epidermis is going to be the first degree burn. And then your second degree burn is going to be the epidermis, which can be divided into superficial dermal burn and deep dermal burn, and they have consequences. And then the full thickness burn will be your anything below the skin. So if you look at the epidermal burn, this is now you going to Durban for December, and you come back and your skin is painful. You do not require any special medical attention because you've got a sunburn. So that is epidermal burn. We usually get it also from steam. When you open a kettle and then you burn in a superficial dermal burn, your skin might, you will see in the next few days, you will see flakes coming off from that skin. That's epidermal burn. You don't need to put anything on it. You don't have to actually treat this patient because they will heal. Now we get to the dermis, which is the critical point of our body's defense. Because if you see, everything that was above was just hair follicles and some sweat glands. Now you are going below the stem cell bed of the patient, right? So there we get superficial dermal burn because they extend only to the papillary layer, as the dermis is said. That is why there is lifting of the papillary layer from the reticular. That is why you get blisters. And if you remove that blister and you point on that patient's burn, it will blanch. It will turn from white to pink immediately. You know you've got a superficial dermal burn. It is usually very painful when underlying visible tissue is exposed. If you remove the blister, it's painful. But these burns will all re-epithelialize if they are given optimal treatment within 7 to 10 days. All of them will epithelialize, all of them will heal and will never have a scar, the entirety of the patient, until the doctor and the nurse come and do something onto them. Then we have a problem. So I will come and talk about what do we do that makes us have such bad outcomes with burns. Now I get to the surgeon's world, which is deep partial thickness burns. They are deep dermal because of the extent into the reticularis dermis, which I explained, the damage to all skin appendages that are listed under that slide, which you will get. That is why they are white. If you remove the blisters, you will see it is white, it is mottled. If you touch it, there's almost like a delayed capillary a refill, or we talk to it as a blanching, delayed blanching with pressure, and the patient is not in that much pain. This is a very sick child. A child with burns who's not in pain is a very, very sick child, and I'll explain to you why. And then the last part is now the full thickness burns, which involve the entire dermis, and they are usually charred, is usually fire. They are leathery. When you touch the baby, it's like leather. They are firm. There's no sensation. This child is walking, it's like, oh, I bent my arm. And there's no blanching at all. Nothing is red. These are the ones that requires early grafting. And unfortunately, these are the patients that, I don't know people, how they think about it. These are the patients I graft the same day. They arrive today, I take them to theater, I clean the burns, I debride every dead tissue, and I put new skin on that day. And I'll explain to you why. Yeah, so just to recap, we talked about the depth of burn, which is going to be the epidermal burn, superficial partial thickness, deep dermal partial thickness, and full thickness. And this is a very nice table. Usually using the lab browser chart, you'll be able to distinguish about what I'm talking about. But if you do not know, I mean, Alessio knows I'm a Vula person. So all the departments I've worked at, you cannot get any of my attention or any referral of any patient without using the Vula app. And I love the Vula app because of burns. On the Vula app, if you open it, you want to refer, there's a baby on it, and you just draw with your finger on your phone. It calculates exactly the percentage of burn. You are able to select what you think of whether it is a superficial or deep dermal. It calculates immediately how much the fluid the patient needs to get and how the patient should get the fluid. So it's an amazing adjunct that you should have. So it will be able to do a schematic presentation, and then thereafter you are able to send also the pictures to me, the recipient. So you also take pictures with your phone. I'm able to look at your pictures. I'm able to look at what Vula is giving so that we can determine the fluid resuscitation. If you miss the fluid resuscitation, no matter where you're sending that patient is not going to leave that hospital. So it's very important to have that, right? So let's look at the physiology of burn. Why is burn such a problem? So you have a patient with 10% burns. Everybody's like, no, it's just a small burn. And this burn, immediately, if it's a deep dermal burn, it elicits the patient's inflammatory response mediators. They get released into the entire system of the body, not the hand, not the burn, the entire system of the body. So the histamines, bradycardians will come through, interleukin-1, and this then, if depending on the rapidness of the release and the percentage of burn or total body surface area, it will elicit a systemic inflammatory response. Once the systemic inflammatory response has started, we are late, because now you've got a microvascular changes. There's going to be increased vascular permeability. So all the fluids that you're going to get, they're going to go straight to the lungs and edema because you are too late. There's going to be hydrostatic microvascular pressure that's going to increase. When that happens, all your sodium, potassium, they are running around like nobody's business into the intravascular and extravascular and cellular. You get immediate electrolyte imbalances. And that now explains why the patients become hyperkalemic, and you are trying to replace the potassium, but now they are getting edema. So, and then what happens is an increased intracellular fluid, which will give you the edema, and there's a decreased intravascular volume. That then is going to give you hemoconcentration. So now you find this patient's HB is a little bit hemoconcentrated, and the clotting factors are not really moving. That is why few days after that, you're going to wonder, what is happening with my patient? Everything is haywire on your blood gas, on your blood results, is because we have allowed this to happen. So the hemodynamic changes once we have the edema, we've got hemoconcentration and electrolyte imbalances, we have an unstoppable patient in front of us that the pediatricians love, because the patient has the hemodynamic changes, there's a decreased cardiac output. Now they are thinking about anadrops. There's an increased systemic vascular resistance, that they are struggling with the blood pressures. There's an increased pulmonary vascular resistance. Now they say, oh, but the patient needs to be intubated. And whatever settings you're setting, you do not really know, why is this patient, what's happening with the patient? And that is because the patient is not only into hypovolemic shock, but they are into cellular shock. And cellular shock and hypovolemic shock, you can try to replace the fluids, the hypovolemic shock, but the cellular shock and hypovolemic shock is going to give you a new term that we're going to give you, called is a burn shock. Now, a burn shock is a very complex pathophysiological management that we will be actually be addressing at our conference, because the management is completely different. So let me just recap on the pathophysiology. Now this patient has bent. We've got two phases that's going to happen. This is where you can, as a doctor, be able to intervene. If you miss this boat, we have a big problem, right? So there's going to be the initial phase, which you call a pro-inflammatory phase. This phase, as I said, it precedes the cell's response, so it affects all organ system. Imagine having a disease that affects everything, and that disease is burns. Cardiovascularly, there's going to be initial hyperdynamic state. So the tachycardia, things are moving. That is going to be followed by myocardial depression and hypovolemia. And you're already late. Once you're treating a patient with burns for hypovolemic shock, you are very late. You should have been at them by the time they have their first tachycardia. The second thing that's going to get pulmonary constriction and edema leading to respiratory failure. Now this explains why a patient that has burned on the legs ends up in ICU ventilated. Then we're going to get what's happening is because our body is trying to deal with providing blood supply to the critical organs, you're going to get GIT splenic vasoconstriction. The gut is going to be dysmotility, it's going to experience dysmotility and malabsorption. That is why patients with burns, suddenly they're not tolerating feeds, they are vomiting, they have a nasogastric tube. Then there's going to be atrophy of the small bowel mucosa. That is why the burns patients now come to this part where they've increased intestinal permeability to normal gut bacteria, which translocates and gives them sepsis. And it's very interesting how much we think the sepsis is from the burn wound, and it is not. This is the critical, actually, cause of systemic sepsis itself. Then we get renal splenic vasoconstriction. There's a release of stress hormones, catecholamines, and decreased renal perfusion. Patient gets oliguric, acute tubular necrosis, renal failure. That is when I call the pediatricians. Guys, the patient is not doing well. And we can and should be intervening before we have this situation. Because the second phase that comes is called the anti-inflammatory phase. There's systemic release of there's a systemic decrease in immune function because of impaired production and function of all your immune cells, which has a double to a tenfold increase in risk of infection. So now that ventilator-acquired pneumonia that was being managed in another patient, the burns patient cannot defend themselves against. That bacterial translocation that happens because you have put the patient NPO, the burns patient cannot deal against. And that superficial wound they have, they've got no defense. You can throw all antibiotics you want to, there's no defense for the patient. So I like this picture because one of my patients I treated at Drop Ferreira, and I was called that the patient has little burns on the face and the arm and the chest, and the patient came like this. And I then, of course, with my team, to myself in person, did a primary and secondary survey to address other injuries, which is something that people forget, that people who get burns, they run away, they break their legs, they break their arm, they have other pathology. Or they are burned by fire, they get carbon monoxide poisoning and other things. So it's very important to do your primary and secondary survey. It's important that if a patient is burned in the face, you need to immediately address airway, breathing, and circulation. And soot from fire, the hot air from fire, is actually what causes airway burns. People think the patient is burned on the lips by fire, that's why they've got airway burn. It's actually caused by the heat that is in a closed room environment. So things like hot water cannot cause airway. If you burn in your lips, your face, you're not going to have airway problems because it's not, unless it was steam, but you can't get it. It's actually from fire. It's from the heat itself that the patient breathes hot air from the flames. That is what causes airway injury. So it's important to be aware of that. And then the most important thing when you are assessing after your primary and secondary survey, you need to ask the question, Did the burn happen less than 3 hours ago? If yes, you can do the first aid. First aid is you need to open the cool water that needs to run over the burn for about 20 minutes. Anything beyond 3 hours is not going to help. It's just going to cause patient to be in hypothermic. So all burns patients, when I say all, I mean all of them, they have to be dried. They need to be kept warm to prevent hypovolemia. This drying happens after you have assessed the wound, you have cleaned the wound, and then you need to draw arterial blood gas to see your status of your metabolism, your full blood count to look at, you need to have a base in terms of your white cell count. You need to have a base in terms of your HB because the fluids you're going to give are going to affect your HB. And then your platelet count is going to be influenced in the future by the platelets and sepsis. You need to know what your urine is so that you can decide on the fluids. Your CMP is deciding on the baseline nutrition of the patient. Albumin is the most important blood to take at that point because it determines when a surgeon is going to be able to take the patient to a skin graft and if that graft will take or not. And of course, the CRP has to be taken on the day of burn so that when we do the CRP after the burn, we can see the trend. So the burn wound has to be cleaned and assessed. And I cannot understand this part. Cleaning it actually means you need to wash the baby, the entire body, not the burn area. Every child who has got burns has to be given ketamine. You can give it ketamine IMI, which I do not prefer because I don't think IMI medications were designed for children. You can give the same dose orally, 5 milligram per kilogram in the child's mouth from the same vial that has the MI. You just put the same vial in 20 ml syringe, the child drinks it, you wait for 30 minutes, it's going to have the same effect on your patient, right? It's important to remember that you need to have oxygen by nasal prongs and monitor the child you give ketamine to. If you are like me, you are busy, you don't have 30 minutes, we have a drip, we give 1 to 2 milligram per kilogram of IVI ketamine titrated. I have never seen a child die from ketamine. It's a very good drug for sedation. As long as you can monitor, it is very reversible and it is a very short half-life. And I'm not sure why people don't give ketamine to children for procedures, especially oral ketamine. If you fail at anything, please just give the child oral ketamine. Please take pictures before cleaning the baby, and then you dress the child. And I'm going to emphasize this: the child has to be washed, the entire body. They have to be put in a thing, and you just scrub them. If you don't know what to use, you have to use Hebe scrub, the one that is at every corner of the hospital. You cannot use any alcohol-containing solution because it burns the child and it's painful. Hebe scrub is everywhere in the hospital. You need to scrub the baby. That's exactly what must happen. It's not happening in theater. The scrubbing of the baby happens in casualty. You have to wash the entire child so that you can take pictures and see the extent of burn, because you have to decide how much fluids the patient is going to get. How do you admit a patient in the ward and you don't know how does the percentage? How are you going to know how much fluids you're giving, right? So the initial management is all blisters, debris has to be removed. You need to scrub the wound, the whole child with Hebe scrub. Some fancy people can use Prontozan. It must be done in a warm place in ED, not in theater, not in the ward, in ED, casualty. It is a quick and ensure that the patient is dry thereafter and avoid hypothermia. Keep the patient dry thereafter, as I said. Lie on dry sheets, cover the burns. You can use bench shield, but bench shield has been out. It's just a waste of money, waste of resources. The best thing you can use at that initial phase is Gelonet, because I am going to remove the dressing in the next 24 hours when I take the patient to theater. So Gelonet, not what is the one that they like so much? Flamazine. It must be banned in South Africa. I'm not sure what happened. Who even brought flamazine into this country? It's one of the worst microbacterial attracting dressing. It causes immense biofilm. It grows bacteria you cannot treat, include like a money. After you put a gel net, you just put apply gauze and bandages. That's it. You have done your job. You have to shave the head of a child with a burn, and you have to shave the head. You can't say no, the head looks fine. You have to shave every child that comes with the burn. It's just the rule, especially if they have burn on the face, because they have burn under the hair. How are you gonna see? You need to then measure the body temperature and record it because of the risk of hypothermia. Once they are hypothermic, they're going to get into coagulopathy and acidosis that your beautiful fluids and your ICU admission is never going to solve. So make sure that you know what's the temperature all the time. Then look at glucose. The important thing about the glucose is we know that children depend on glucose. The brain only works on glucose as a child. You don't give them glucose. You can give them as much ringas as you want to. The patient is not going to do well. So the second part is now we have to put IV access. The child has to have two large borehole lines, not one peripheral line there and we don't know what's happening. They have to have two. And I'll explain why, because they are getting two different fluids. The first fluid they are getting is according to Parkland's formula, is called resuscitation fluid. But then they have to get food in the form of dextrose contains a solution. It can't run in the same drip because there are two different fluids mixed differently and given at different rates and at different intervals. So there is no, every burn child has to have two peripheral lines. That's just the way it is. So the best line you can give is intraosseous line, which should be there. It's not really difficult to do intraosseous line. It's done at every medical school. It's part of the training. It does not need a surgeon. I just want to emphasize, I mean, I emphasize this a lot, even in my clinical practice. I have never seen any book in medicine, including ATLS, BLS, advanced trauma, anything that has a central line in that book. A central line is not a line for resuscitation. If you have a resource that shows that a patient that needs resuscitation is a central line, you are welcome to bring me that resource. It is not a line for resuscitating a patient. It's a line for something else, which I'll talk about later. So two peripheral lines are going to save your patient. Fluid resuscitation should be initiated as soon as possible. You need to know exactly how much fluid did the base hospital give, how much fluid was in the ambulance, so that you can initiate your Parkland modified fluid, because it has to include what the patient was given. So it's modified because it runs at 3 mils per kilogram per total body surface area with maintenance fluid added to it. So if you don't know how much your patient weighs, clearly you're not going to give the patient what they need. If you do not know the total body surface area because you refuse to scrub the patient, clearly you're not going to know how much fluid you're going to give. And you need to be aware that is just resuscitation. Then you need to look at your maintenance, which you can use the rule of 4-2-1 if they are more than 10 kilograms, or 125 mils per kilogram per day if they're less than 10 kilograms. And these are two different fluids given the same time to the patient. The dextrose containing solution, it is isotonic. You can actually use ringers lactate with 5% dextrose if you don't want to give both ringers and have the D as two different lines as well. And I cannot understand how do we resuscitate a patient with fluids and not have a urinary catheter. The only way to measure if the fluid you are giving to a human being is by looking at urine output. There's no other way. It's not the blood gas. It's not if the acidosis changes. It's the urinary catheter. You have to put a urinary catheter immediately, resuscitate the patient. Whether it's a trauma patient, whether it's a patient in septic shock, any other shock, there has to be a urine output. And we want this patient's urine output to be 0.5 to 1 milligram per kilogram per hour. Because if they are not, we need to change our strategy of fluid resuscitation. That thing, you need to give them analgesia, all of them. Inadequate analgesia will exacerbate hemodynamic instability. If you remember the hemodynamic responses and modulators I spoke about. So, I mean, I give my patients with burns, they're going to get an morphine infusion the same day. Nutrition is very important. No patient in the 2 burns units I've run in my career comes to my ward without a nasogastric tube. Burns cause increased catabolism necessary to adequate nutrition support. You need to insert a nasogastric tube. If any patient is not able to feed, or the patient has more than 20% total surface area burn. The reason why, because you're in a catabolic state, you need 3 grams of protein in your body. That is 2 chickens and 1 pizza every 3 hours. And if you're not giving it, you have to give it by supplementation, because clearly we know that a child cannot get 2 chickens and a pizza. So that is why nasogastric tube is important. Then we need to look at the wound care. The patient wound has to be scrubbed thoroughly with warm water and chlorhexidine soap, and dress the wound to maintain the moisture. Moisture is very important, and I'll explain to you why. So that is just the initial resuscitation of a child before you can even call anybody about the patient. That's just the basics. There is no role in any published literature in the world about prophylactic antibiotics in acute burns. None, 0. There is no, the patient has not infection, he's got burns. So there's no role for prophylactic antibiotics until you have proven systemic sepsis. Even if the wound comes and the wound is infected, that is not systemic sepsis. And as I told you that there's a zone of coagulation, the zone of hypoperfusion, your IV antibiotics will never reach that zone because there's no blood supply. So you can give as much vancomycin as you want to, you're not going to have the patient. Burn wounds are treated with topical antimicrobials and debridement, and they do not need any antibiotics. Antibiotics are only prescribed for a patient that has systemic sepsis as a result of the burn. You can consult the pediatric surgeon on call or use Vula app, which is used in all pediatric surgery units across the country. You can discuss where the patient should be managed, because you need to know, is this patient going to be managed at my local hospital, or they need to be or be transferred. You can ask us about the need for resuscitation, how it should be done. The aim basically is for a patient to be in the ward within 4 hours after arriving in the ED. That is the international standard of management of burns children. Insert the urinary catheter, I will say it again, and ensure that the drips are working before the child leaves the unit, because now the drip is out, the baby is still in the unit. It's in the ward now, and nobody knows what's the urine output. But now the baby nappies are wet. Please write down how much fluid was given so that we know. As we know that the resuscitation fluid are given half in the first 8 hours and the other half in the next 16 hours. We need to know exactly where it was given when and the time zones. Now the patient gets admitted. Who gets admitted to any hospital? They don't need to be transferred to any secondary hospital or any, they can be admitted. Is anybody that has about 10% burns, that's usually not a problem. If they are partial thickness or superficial dermal burns, because, and I'll explain to you why, because I said they all heal. They will never need a skin graft. They will never need develop a contracture. They are superficial dermal burns. You need to, although you have to do a blood gas before admitting the patient to the ward so that you can know what is the hemodynamic status. You need to have a working line that must be confirmed and an NG tube if the child is unable to feed. But if they are able to feed and it's around that area, they need to be admitted as well. You need to dress as per discussion with, you can use Gelonet, Sobect. If it's dry, Aquacell, Acticoat, but you know, this, they need guidelines which I'll provide, share with you guys. It's not something that you can decide about at that time. The dressing change depends on the type of dressing used. Some dressings has to be done one every daily, and every time the sisters change the dressing, they have to wash the wound. You don't remove the dirty dressing and put a clean dressing on it. You need to scrub the patient all the time. Some dressings are 3 to 5 days, and I prefer doing my dressings that are that long in theater. All patients discharged should be followed up. If they're less than 10% and you think they're fine, they should be followed up in the clinic 5 to 7 days later. TTO has to include Panado or ibuprofen syrup for pain. Unless it's in acute phase, then NSAIDs are not actually recommended. The patient that needs to be referred to either a Benz ward, Benz referrals, pediatric surgeon, specialist, it's moderate burns. Every partial thickness burns above 15%. That patient is so sick, you have no idea. I did say that just the anterior part of the chest is 13%. Imagine you've burned the whole chest and the leg and 2 legs. That is more than 15%. That patient needs everything to be thrown at them. Or smaller total surface area that are unstable patient, depending on whether there's fire. All deep dermal burns, more than 10%, have to be admitted because we have said deep dermal burns needs skin graft. All of them. Every deep dermal burn, you can put as many dressings as you want to, for as long as you want to. It will never heal. After 21 days, after burn, if a burn wound has not healed, that patient needs a skin graft. There's nothing else that will heal them. 21 days has passed, they need a skin graft. All full thickness burns, they need a skin graft. Chemical burns, they need to be admitted, and you can't put water on them. You can't put certain dressings on them because it just reacts and they burn. So a chemical burn, you need to call a burn specialist. Inhalational burns from fire and electric burns, because they need ECG monitoring, is important. Even if it's just a small wound on the finger, they need to be admitted for ECG monitoring. You can discuss with pediatric surgery on call. I'm always on call for burns. Even Nikki, we have committed our life. I'm on call 24/7 for burns. My VULA says on call for burn. You can look for me anywhere. I will answer if you've got a burn child. Before admitting or referring the patient to wherever you are referring, it doesn't have to come to me, but I'll be able to give advice because it's an easy advice to give. And then now comes to the patients that needs to go to ICU. Any major burn, if it's a superficial burn that is more than 20%, that patient needs critical care. Whether they need ventilation or not, they need critical care. Deep dermal burns, more than 15%, that patient needs critical care because of the slide I shared earlier. Full thickness burns, chemical burns that I've described, we should consider them, but all this patient has to be, you have to consult a pediatric surgeon and decide if there's a need for admission in ICU. You need to discuss with the pediatrician. You need to get a bed and manage the patient after discussion, because these two people are now critical in managing this patient. The problem after 20% is not the wound, it's systemic response to that wound. Okay, this is what's going to happen. Patient's going to have a trial of death if they don't go there. Hypothermia, coagulopathy, and acidosis. And we all know about this because we've been taught about this. I'm probably at the end of the thing. I want to present a case. So this is a 7-year-old male who came to Rob Ferreira after he was in Mapulaneng for 7 days. The child's dress caught alight 2 hours. This one was 2 hours ago. Yeah, the registrar, they caught fire 2 hours ago before they went to Mapulaneng. She had no comorbidities and the weight was 22 kilograms. Can anybody volunteer to manage this patient according to these principles that I gave?
Colleagues, you can raise your hand if you would love to give it a try. I see we have historic hands. Let me lower them and then we start. Yeah, colleagues, anyone who wants to give it a try, you can also type, but it will be nice. Dr. Mudiwa, your hand is up. I guess you want to try. You can unmute.
Yeah. Good evening, everyone. Thanks, Les. I mean, I'll try my best to see if I can manage according to what Dr. Motlowe said. So with the duration of the hours within the 3 hours that he highlighted, I think we can try and put the child in the cold water, put him in hot for 20 minutes to cool down, and then after putting him on that, try to give him some analgesic, and try to clean the wound, as he said.
How much ketamine are you gonna give? How much ketamine are you gonna give? And how are
So
you
the
gonna
ketamine will be,
administer it?
I'll have to put some IV line, put 1 to 2 milligrams per kilo, or I can give oral 5 milligrams per kilo. Since you
Good,
don't
because
recommend
this child, you can
IV.
see this child's mouth is fine. She's
Yes,
fine. So you can give him oral ketamine. It's not a problem. Just give him oral
yes.
ketamine. It's actually good.
Yes,
Yeah.
oral ketamine. Yes, I can give oral ketamine with him, which most probably it will be 22 multiplied by the
Good.
5 kg with him, and then give it to him, and then also try to clean the wound and put some Jolonet on him. Yeah.
Good. Good. You have managed the
And
wound. Now manage the patient.
yeah, so I have to try and put the fluid on the patient. So obviously, I will have to try to classify my wound in terms
Good.
of the classification of TB, and then looking at the wounds. I forgot that graph in terms of how much is it in terms of.
I like that. I like that because you don't have to remember any graph.
Yeah.
You open
So you
your
can
app,
take pictures.
yeah, and Vula tells you.
Yes.
Yeah, you don't have to remember anything with bands. Everything is online. Right? Good.
Yes.
And then
So I
do you
can
think what's the depth of bend on this patient?
this one looks like it's a partial thickness bends.
Yeah. So if you look at the right arm, you get epidermal band.
Yes.
And then if you look at the abdomen here, it's a superficial partial thickness
Superficial,
band.
but
If
yeah.
you look centrally, it's a deep dermal band. If you look on the chest, it's a full thickness band. So this patient, you don't even know the depth and extent of the band. So you cannot really know what's going to happen to this patient. And I can also give you the clues. He has a burn on the cheek. The mouth is fine, and it was a flame burn. Right? Any
Okay.
other thing you are worried about?
On the head, I'm worried about the head because it's on the face also. So I'll have to cut the head also. The hair, sorry.
All right. Yeah, so that's very good. I'm glad with that. So this patient was just managed like initially before they came, and I know this picture came now 4 days later after the management, and this patient was now admitted in ICU, was ventilated because they had the head was a certain material that bent, so it's a plasticky material. She went onto the bed to try to stop it, and the bed caught fire because there was silk. And that kuboyani arona, that that thick blanket that we buy, I don't know where we buy it, it caught fire. The actual room caught fire. And this is what had happened. The mechanism was very important because nobody realized this patient was going to have airway problem, and they did get into airway problem, right? So this is after, if you look at that, and this is after the patient arrived. We resuscitated the patient. He arrived on us on day 5. Serious resuscitation, ICU, trying to get the patient. All the hemodynamics were abnormal. I needed to take this patient to theater for debridement. All dead tissue has to go. Not dressed, not under gelinet. This is how a burn wound needs to look like on day 7, right? And then on day 22, they went again to theater for me to go clean again and change the dressings. And this is how it looked like, because I was preparing to graft, and I wanted to see, if you look at it, you think, oh, it's gonna be lots of grafting happening. After day 22, the patient is in theater. I do not care how the wounds looks like. They come for skin graft. There is no wound that should be more than 21 days. If you've got a patient in your ward that has been there with a wound for a month, sister, you need to call HPCSA and say the doctor is not taking the patient for skin graft. It's never going to heal. It will never heal. It is proven. 22 days, patient has to go to theater for skin graft, right? So the patient, of course, got a skin graft, and this is now on day 28. I opened the wounds again, and it's very important to see how the time frames, 22, 28. Once I graft you, nobody touches your wound until 5 to 7 days later. Every time you remove the dressing, you disturb the body's way of healing. You only remove a dressing on a dirty wound. So if you're gonna do dressings every day, like people use flamazine, it will not heal. Like you put flamazine today, tomorrow you remove it, the wound bed is trying to heal, it starts from scratch. That's why your patient is gonna be in hospital for 3 months, right? So you need to know what dressings to use, and I will give guidelines for that. So this is at 35 days later. And do you know why this patient is, can you see the contractures? Can somebody tell me why they got the contractures on the chest? On the right side of the chest.
Volunteer. Or Mudiba, you are still live. Why? Otherwise, colleagues, anyone can volunteer. You can type it in the chat. Nokubonga says full thickness bands.
It was full thickness bands.
And
Yeah,
saying says no
bands, right?
physio or something. Full thickness bands. Yeah.
Yeah, it's full thickness bands.
Mm.
Yeah. We do not like to mobilize the area we grafted because it can disturb the graft. It was because of full thickness bands. And I want to address the questions. People say you must admit circumferential bands because they're gonna get a contracture or bend through the joint. They're gonna get a contracture. That's not true. How can a superficial dermal band, partial thickness, get a contracture? It's above the collagen layer. It can't get a contracture. So the correct answer is deep dermal bands that are circumferential, deep dermal bands that are above the joint. So you need to be able to classify the wound so that you know which ones are going to cause contractures. I just want to give a
Hi team, just to
I
say
usually
I'll
give
join you
reference.
shortly. Just closing a training event. Sorry.
All right. Can I still continue?
Yeah, sorry, I was not muted. I was talking to some people. Sorry about that. Yeah, sure.
Yeah. So people always talk about the burn center. There's nothing like a burn center in South Africa, in both public and in private sector. Maybe we might have one in Cape Town, which is run by Prof. Rode. I think Tendo and his team have one now in Barra. And I'm not sure of any other place that has a burn center or burn unit, or George Macari as well. But there's burns everywhere. So it's about capacitating people. And there's no burn specialist. Sometimes people say they are sending patients to plastic surgeons for burns, but it's a child with 30% burns who's got need resuscitation. By the time you need to graft, you need a plastic surgeon after 21 days. What's happening between that and 21 days? So it's about capacitating. This is the first group of concepts. I had the picture on the top. They are the ones that inspired me to start the first Ben's ward. I don't call it Ben's unit in Mpumalanga. And they are very, very good Ben's. I call them Ben's specialists, whoever they are. There is nobody who will tell them about Ben's because they took the time to read about Ben's, to go to the trainings. There is a Grace laparoscopic suturing and band skills course that is mandatory to all the doctors that work with me. You can attend that. It's a very good band skill course. And then after that, this is the second group that joined a year after. They basically also were trained, and we opened only four bands ward in Bombela, and I'm so thrilled to see these young people. They are actually running the Benz ward without a specialist. They send me pictures because I'm in Medusa now on Vula. They have run that ward. They have incredible success stories of how children are working out of that unit, and the Benz unit itself was sponsored by Paediatric Care Africa and the Bombela business people, and it's a state of the art. It has everything you can think of that any rich hospital can have, and it's about taking initiative in your hospital and say, I'm going to solve this band's matter. And then that should be it. Thank you very much, guys, for giving me your time. Sorry we started late. And now you can ask questions.
Awesome, awesome. Colleagues, I think, as we are about to engage probably for like a few minutes, it reminds me that I always say, show me a person who has stopped growing, and I'll show you a person who have stopped making trade-offs. Imagine if you had decided that there are delays, I'm not joining. You would have missed so much, so much, so much. So there's nothing of significance that happens downstream. It's always upstream. And to go up, you must give up something. To get this information today, you had to make a trade-off, either your family time or somewhere else you could have been. You decided to be here, and we are so thankful for that. So thank you so much, Doc. I think very, very, very empowering session. Love it, love it, love it. But I think we need to repeat it, even if it's in the current form. There's a lot of nuggets, and there are specific slides where I felt your advocacy voice, and one of your voices said that must be sent to HPCSA. But I think there were also places where I just laughed. 2 chickens and a pizza, so full
Yeah,
of.
that's 3 grams. That's how much you need, 30 grams.
So we were listening, we were kept on the screen, and which I really just want to say thank you so much for that. Yeah, maybe let's go through a couple of questions. Colleagues, I can't promise that we'll go through all of them because of time, but let's see how it goes. There was a question by Franklin earlier on saying, if the epidemic is a neural, how come the skin helps in sensation? But I think you addressed it by explaining at which levels.
I can answer. You must
Yes.
remember the skin is dermis and epidermis. The skin is dermis and epidermis. That is why it helps in sensation. If the epidermis was having nerve fibers, every time we bath, we should be crying. Because then the neural cells will be painful. Yeah.
Awesome. No, I think this one is fine. Someone was asking, can we wash post bands with betadine? Can we use betadine solution?
Betadine should not be in a hospital. I believe we are in 2025. We've got chlorhexidine, which is a better solution. Every government hospital is on tender. So just order things.
All right.
So what
fine.
actually betadine does, I just want to talk about the betadine. Betadine actually removes bacteria, is antiseptic, it removes bacteria, but it does not sustain the biofilm. So in 30 minutes, bacteria can grow again. Whereas chlorhexidine maintains the place sterile. Sorry.
Okay. I don't know about Silbecore for bands.
Yeah, I mean, there's lots of dressings that you can really use. At the end of the day, I think dressings starts happening in theater with a surgeon. If Gelonate is the best thing that ever made, just as long as the wound is clean,
Awesome.
you must keep it moist, keep it clean, and that's it. Anything beyond that, you now need to consult and look at the different. It's a wet wound, dry wound, because all these dressings work for different things.
Awesome. I think when you spoke about the central line not for resus, this is when this question also came up to say if you are unable to get proper lines and you do not have resources for the intraosseous line, what else can be considered for resus?
Yeah. So from what I know, a green needle and a black needle, intraosseous line. I'm not sure if they're called resources. They are there. You just drill them onto the tibia and you've got a line. I mean, there are very few places that is a intraosseous gun. Two needles in that can fit into each other. You can drill them and you've got intraosseous line. Of course, there's complications. You can't do an intraosseous line over a burn and all that. But the reason why I emphasize this, and I'm not just poking holes, is because every person that gets resuscitated, there's this idea that they need a central venous line, but I can't find it in any manual of resuscitation. I mean, people do CPR on a human being with a CVP. There's not even an algorithm for it.
Yeah, so we will have to do a master class on this, Doc. But let's talk about the 6th of November and see if there's a way to stream so that colleagues who can be there physically can still join. But that's a discussion between me and you, maybe after this session.
Yeah.
I know my people here would be very happy to be part of that.
Yeah.
The issue of private versus public, where public, I'm sure you're reading the question. It's like in private, they don't do the scrubbing or something like that. And Valencia is asking, is it based on resources or what? It's like in private, the recommendation is. Yeah, you can respond to it. I'm sure you can say it. Yeah.
Yeah, I mean, I do both private and public health medicine, and any doctor that has called me from a private hospital, they know I'm gonna tell them to watch. I never use the word scrub, because if you use the word scrub, you scare doctors. I say, please wash the patient, because that's what you must do. You must just wash the baby, bath the baby. And I have never accepted any patient from any ED without the patient being washed. So you need to wash the baby. All debris needs to be removed so that we can assess how can they tell me what's the percentage of burn, the depth of burn, how the burn looks like. They've not washed the baby. You just have to wash the baby. It's part of management.
Awesome. Hey, these questions, they are flying. Okay, let's see. Okay, does the presence of SLAF mean the patient is at a higher risk of infection and requires prophylactic antibiotics despite an increase in septic markers? Or maybe you mean the markers are normal, but there's a SLAF. I don't know the question, yeah.
I'll answer that question by showing this again. This is a burn wound. It's zone of coagulation. All tissue is dead there. And there's SLAF there. And then there's also SLAF here with area of stasis.
Doc,
so
reshare your slide. Sorry, reshare your slide.
Oh, sorry.
Yeah.
All right. Sorry, but it's fine.
Okay.
I'm going to give you guys these slides again, but
okay.
It doesn't matter now. Yeah. So basically, antibiotics do not treat wounds because there's dead tissue. It can't penetrate the wound. It can't do anything. And systemic antibiotics is for systemic sepsis. The wound has caused now systemic sepsis onto the patient, and that's the only way. That's why you only give antibiotics after you've got a positive blood culture. You don't have nobody does wound swabs for burns. If you swap a Ben wound, it comes as polymicrobial. It needs collagen, all of them. They need antibiotics you don't even know. They're not even described because it's bacteria growing there. And so the treatment for a burn wound and slough is debridement. It is not antibiotics. It's debridement. Patient has to go to theater to be debrided.
Okay. Awesome. Two things. If you can remember, you said there's a link for the workshop.
Yeah. I'm gonna give you to the workshop. I'll give you the link. You put it. To be done by. It's the same workshop that is done at Pietermaritzburg, but it's not a half-day course because we decided we need to include medical people. We will be training you on how to put lines. I am very particular about how to put lines under ultrasound guidance. So I'll be training people how to put PIC lines and how to do because I believe in PIC lines over peripheral lines, so ultrasound guided lines and all that. That's why we are stretching it over a whole day.
Yeah, maybe colleagues, let's do it this way.
But
Doc,
I'll share
Doc
the
will
link.
give me the links and then I will send it via email to everyone. But if you I think that's a fair enough. Colleagues, we are going to take the last two questions. Maybe on resuscitation. Apart from ringers lactate, what other IV fluids are preferred? I know it's not even ringers, isn't it? The resuscitation by the pediatricians has changed, but I don't know from a surgeon. What do you use, Doc? Because I know they've moved away from
I think
BDs
you
and
must.
those kinds of things. Yeah.
Yeah, I mean they are different. I'm talking about what we have available in our. We use ringers lactate because you are resuscitating. You need to use crystalloids. There are only two crystalloids we have in the state. It's ringers lactate and normal saline. The next one is blood. Yeah, unless and blood. Any other fluid is not for resuscitation. It's for maintenance.
Yeah.
Unless you are looking at Bausol and other things that we have in the private sector. But Voluven was out long time ago.
Doc, do you think there's a place for an M&M for bands? It would be nice if we can host a monthly virtual thing and people can present their bands cases and it would be nice. I don't know.
Nikki would love that. I would also love that. I would support that. Where people have different bands and they ask for advice. We actually have a Vula for bands that's 24 hours online. If I don't answer, Nikki answers. So we love to help people who wants to be involved in bands.
Yeah, colleagues, be on the lookout for this one. I think it will be a very interesting thing if we can allocate an hour once a month, and those who have had bands throughout the country can come and present your cases. You get feedback. It will be a learning platform than a critique platform. So I think it will be because that's how improvement happens. We always have to reflect on your practice and then see what is it that you can do for your next case. That's how we learn in medicine. The second before last, what material was used for the skin graft in that case, Doc? The one you presented.
Skin.
Okay.
Yeah. So I like the question. So basically there are different ways of skin grafting. The only skin that is gonna stay on the patient is the patient's own skin. Even if we get a donor skin or cadaver skin, it lasts for two weeks and it falls off. I've used fish skin and other skins, but they're all called just to cover. They will fall off. The only skin that will ever stay on you is your own skin, or your skin that is cultured in the lab, your own skin, and because it's basically an organ transplant.
Awesome. Maybe you can close by, just because there's a number of questions about fluid resuscitation. Maybe this one will elaborate on fluid resuscitation. Maybe though I think it was covered, but I don't know if you would want to give colleagues specific advice around fluids.
Yeah. I think you need to look at modified Park lens because it's modified because in adults it's 2 to 4. It's modified in children because it's 3 mL per kilogram. You need to then take the patient's total body surface area of burn and you multiply by the child's weight. So 10% burns in a 10 kilogram is 10 times 10, which is 100, and you times that by 3 meals, you've got your meals. Then you would then give half of that fluid in the first 8 hours since the burn, and then the rest of the half is then given 16 hours later. That is just resuscitation burns fluid, but the patient still has to be on maintenance fluid that we usually calculate for anybody that we are giving, that we have either kept NPO for any other reason, which is 4-to-1 resin or whatever fluid you want to give, which is dextrose containing fluid. And then you need to look at your losses. The patients who have losses that needs to be replaced, then you replace. But early enteral feeding is 100% important. And if you cannot give my patient 2 chicken and a pizza, please put in a gastric tube, call a dietitian, and give them enteral feeds. I'm now out of. Thank you. Thank you. Thank you. Thank you. Thank you. Thank you. Thank you.
I'm muted. I was actually thanking you to say to have over 700 of you after 8 being with us. It's encouraging. And I was also appreciating Dr. Mutloung as well for his time and really seeing us through. For me, it feels like one of those biggest decision I have made for myself, just to be here and to learn about this. Doc, your closing remarks, and then we call it a night. And colleagues, we're going to have a repeat of this webinar, I can assure you, so that you can. And for our members, remember you'll have access to the micro lesson and you'll have time to pause, fast forward, rewind, Dr. Mutloung, as needed. Thank you. Am I still muted? Hello? Yeah, you can hear me. Dr. Mutloung? Colleagues, can you hear me? Unmute. Why? Something is not right. Oh, you can hear me. Okay. Dr. Mutloung, are you still here? I think you might be muted. No, he's not muted. But I can't hear him. I'm not sure what to do. Okay. Can you guys hear Dr. Mutloung as he says bye-bye? Because if you can hear him, then it's fine. Because I don't know what's happening here. Something happened to my thing. Okay, colleagues, if you can hear me, good night, good night, good night. We will update you on some of the upcoming events around pediatric surgery, bands, skills on suturing. There's a lot that I think we will bring on board with Dr. Mutloung. Night, night. Sorry about that.
In today's fast-paced world, keeping up with the latest medical knowledge can be a challenge, especially for healthcare workers striving to provide the best care possible. Introducing the Clinical Care Platform, a proudly South African, wholly owned online subscription edutech company built for healthcare professionals. Our mission is simple: to improve patient care by increasing access to high-quality, evidence-based educational resources, anywhere, anytime. With With our membership subscription, you gain unlimited access to a growing library of over 155 CPD accredited courses, weekly micro lessons, and 10% discount on paid e-learning courses, all curated to align with local and global guidelines. Join live webinars, over 160 sessions and counting, earn CPD points on your schedule, and download key clinical resources, including templates, research reports, and practice guidelines. Subscribe, get educated, earn CPD points. With the clinical care platform, lifelong learning is just a click away.